for health economics, health policy, and health systems analysis. We realize that this is not a once-off thing. It's something that needs to keep happening. And even if we cannot act now, the conversation has to begin. And that's why we're kind of having this meeting today. And we know the capacity needs on the continent is not just about people who are trained as health economists, but also people who are within the ministries of health, ministries of finance, social development, and other allied ministries who might need to understand some economic outputs and interpret them and use them for policy. Sometimes the capacity needs could be having someone who is trained as a health economist or health policy or systems person sitting within ministries of health to be able to translate hardcore economic evidence to policy. Through discussions, we found that there were many challenges, one challenge we identified easily is the parachute approach, where we have experts coming in from the global north to sort of transfer skills to the global south, but that never happens because at the end of the day, they come in and they go out, and the local communities remain impoverished and they remain incapable of doing what they should be doing. And this has been going on, and capacity gaps keep widening. And sometimes, again, we found that so many people are trained on the soil here in Africa, but in the end, they don't retain skills on the continent, or there is no way of giving back to the continent. So they are trained, and as soon as they are trained, they are poached and they leave the continent. So skill drain becomes a chronic problem that keeps rotating from generation to generation. So how can we kind of alleviate the skills gap? Is one of the things we talked about. So to begin, I am John Ataguba. I am the Executive Director of the African Health Economics and Policy Association. Then my day job, I hold the Canada Research Chair in Health Economics at the University of Manitoba in Canada. I used to be at the Health Economics Unit, University of Cape Town. I used to be the director of the Health Economics Unit here at the University of Cape Town when we actually bidded to come to Cape Town to host AHIA. So I'm coming in now in another capacity as the Executive Director of African Health Economics and Policy Association, welcoming you also to the continent. We at AFIA, we have partnered a lot with other organizations, including Africa CDC Centers for Disease Control and Prevention. We've also partnered with Kemri Wellcome Trust in Kenya. We've partnered with so many other local institutions on the continent, and with great support from many other institutions, including the WHO, UNFPA, CHAI, and many others. I wish I could keep calling them. IDRC, Bill and Melinda Gates, and many others. We partnered with them on many things, including capacity and development. And we've continued to see the same problem propping up. How can we build and strengthen capacities on the continent to avoid, like I say, brain drain, and also to train and retrain? One striking thing that we saw was that many of our fresh graduates, as soon as they leave the graduate programs, they are not very prepared to fit within the ministries of health where they should be. Many of them, to a large extent, are able to fit back into the university to become teachers, but we don't need all trained health economists to be teachers. We need people to go back into the system to be able to keep the engine running. And that's where we think the bulk of our trained health economists and health policy or systems experts should be based. But unfortunately, they don't have the skills. As simple as giving them a very simple task to do within the Ministry of Health, they're lost. They also need some kind of refresher course or program. As a follow-up to that, we will have what we call an All Africa event happening on the 10th, which is tomorrow, in the evening at the Gold Restaurant. So if you want to know more, I'm happy to give you, we'll carry on this discussion to a restaurant. So in Nigeria, we'll call it, what we call workshop in Nigeria, we'll say it's walk and chop. If you know what that means. That's what when a Nigerian tells you we're going for a workshop, it's walking and chopping, like it's a slang. So we'll be having a walking session where we eat and also talk about capacity development challenges and how to build capacities and strengthen capacities on the African continent to meet African challenges. Another thing we figured out is the training that our graduates get. Are they being trained for the local market, or are they being trained for somewhere else? And that determines a lot, that determines the trajectory that they follow. Because most of the training, many of them are trained for a different market. So it's easier for that market to poach them because they are pretty much ready for that market. But they are not so well ready for the market where they should fit in. As a result of that, so many of them, I've heard a lot of complaints from others. Well, I've applied, they're not taking me. Why? Because the skills you have are not the skills the Ministry of Health needs at that moment. So sometimes it's difficult for them to justify why they have to hire you. But it's easier for you to get a position in somewhere in Netherlands with all your skills, and you're easily taken in. So these are things that we will be talking about. So we have a panel lined up for you with diverse interests and experience from different countries, from South Africa, from Rwanda, from Ethiopia, and of course, the entire African continent, from Malawi as well, to talk a lot about these issues in terms of capacity gaps, challenges, and not just talking about problems, okay? It's important to raise. It's not, we've been hearing this problem over and over again, but also to begin to brainstorm in terms of what are the innovative ways of getting, if there are innovative ways of getting around this, let's begin to think about them. And what are the unique African ways of getting around capacity challenges and gaps? How do we fill them? This is an opportunity for everyone to make inputs into the process. So we will begin first by calling our panelists up. I hope they're all ready. I think so. They're all ready. If you're not ready, then we'll give you Red Bull, and then you will be ready. The reason why I raised Red Bull was that I had a heated argument with a lady when I was heading up to my room, and then she saw me. She said, "I saw you yesterday at the bar. You took a Red Bull. You paid 45." And I said, "Not me." She kept going on and on and on and on that you are the one. I'm like, "Not me." So the kids felt that their mom is going crazy. They told her to kind of calm down. She said, no, I know this guy. He took Red Bull, 45 rand. I'm like, "Oh, you even knew the exact amount." She said, "I paid $50 and it was 45. Like, "No, not me." So maybe we'll give you guys a Red Bull. And the woman was on my case. So without further ado, I will like to introduce them in no order, no order, but I will kind of jig them. I will call to the stage Dr. Regis Hitimana. Dr. Regis Hitimana is from Rwanda. He works at the Rwanda Social Security Board, which we usually call RSSB. He is the Chief Benefits Officer. We would also like to welcome to the stage Kate Langwe from the Ministry of Health in Malawi. Malawi is a very interesting country that I would want to visit one day. And I also want to call Professor Sheetal Silal. She's at the University of Cape Town, Department of Statistics, and she is the director of MASHA, which is an institute she formed as a baby. I will also welcome Dr. Vishal Brijal, who is with Clinton Health Access Initiative. I'm giving him an honorary, so he should know what that means in my capacity. I also want to welcome Dr. Miraf Tadesi Tola, who works with the Africa Centers for Disease Control and Prevention in Addis Ababa. I think that is all. I didn't miss anyone. I miss myself. It's okay. I'm irrelevant in this equation. In economics, we call it the independence of irrelevant alternatives. So when you take me out, the rest should still maintain their order. So please, you can take your seats. Okay, I think we will have opportunity to hear from each of you. We'll give you 10 minutes basically to go over what you think are the key challenges. It's also good to know the problems, not just go straight to solution when people are trying to figure out what the solutions are. But to know the key challenges in terms of capacity building on the African continent. But if you have insights within your own country or context, that will really help us. And also, if there are solutions that you want to that you think can be put on the table, and also lessons that you've learned in the process. Maybe you have at some point initiated a capacity strengthening or building activity in your own capacity. What are the kind of lessons that you've learned that we can also bring on board? At some point, we'll have open discussion where we have people inputting from different aspects, whether you're within academia or you're in government circles or etc. We'll talk. We'll open it up. But let me start with you, Dr. Regis Itimana. In 10 minutes, tell us basically about what I have raised. If you have, if anytime you're ready, you said.
Have already delayed. I hope it is working. Yes, I think on the African continent, as it is the case elsewhere, we have limited resources and we need to allocate them efficiently. And it's more, the problem is more, how can I say, it's bigger in Africa than in many other parts of the world. So, and decisions are being made. That's what I always argue with. So if they are wrong, then we should act now. So if you are misallocating the few resources that we have and not getting the most outcome out of it, it's already a wrong decision and we should act now. And we don't have, I think, to have that fully fledged health economics unit in the ministry, or so, because if there is, even if it is one person who knows what to do and who can help the system decide better, even if it is a small decision, I think it will make a huge impact. When I was reflecting on this topic, when I remembered the 2010 when I joined the Ministry of Health in the planning department. At that time, there was no health economics, health financing unit at all. It was the head of planning who was, if you are done with the budget, then health financing is done. And a small other unit of CBHI, which was at that time 10 years old, that was coordinating district pools, CBHI pools. And a small, I think 3 or 4 team of PBF. So it was multiple teams scattered here and there, no coordination, no health financing plan or strategy. And I think the first health financing strategy came a few years later. And now we still have the head of planning coordinating health financing, but there is a separate health financing unit, at least, to coordinate the policy level and the implementation. So I think this is an evolving subject, and people are getting lesson, and they are realizing that in addition to having small initiatives, at that time there were more partner-led, more experimental. If I talk about PBF, than now becoming a national policy that the ministry signs off, and there is a unit to ensure that it is happening, and pushing all the partners to align around the one strategy. So talking from that was when I was in the ministry. Now I am with the National Institute that is managing health insurance, 2 health insurance schemes. and other schemes, social security schemes, but I focus on the two health insurance schemes. When I will see what is happening in terms of capacity, the institution has let me see, I think 25 years experience in managing one scheme, and now 9 years managing CBHI, which is big, which is covering more than 90% of close to 90% of the population. And what is the capacity do we have? From the academic, as John said, we don't get people ready to be employed in the health insurance, if I may say. If you are calling for someone with a master's in health financing, you get, I think, 1 or 2 who were trained here in South Africa, 1 who was trained in Europe. Some of them didn't come back. And where they are, you can't get them into the RSSP because they are busy with what they do. So you end up recruiting either economists or medical doctors and give them an opportunity to pursue either master's or PhD degree. As I'm speaking now, the head of CBHI is pursuing a PhD in health economics, and the head of the other scheme is a medical doctor who is pursuing a master's in health financing and health economics. So that means we allow them time to do that as part of their busy schedule, and they do research on what they do in work. So, but that is not sufficient, if I may say. And there is no good approach that is better than the other. I think complementarity and combination of approaches work. That's why we have technical assistance. We have a number of organizations that provide technical assistance directly. They bring in experts from Africa, from across the world, bringing their skills, and they work with our teams, coaching, mentoring, sometimes co-creation. Sometimes the person comes with either a slightly different experience, but together, I think they build strong teams that are facing the question, the challenge, and finding solutions together and bringing a diverse experience. I think it helps. Of course, there is a risk of feeling that capacity filling rather than capacity building if we are not careful, if we are not sufficiently careful. And what we try to do is to try to pair a TA with someone in RSSB who is taking over, and keep pushing them to see, this person has supported you doing this job, can you do it next year? And we have examples. In other cases, we have secondment, and I think so far it is only CHI, Clinton Health Access Initiative, that second staff to RSSP. I think I see it as the most appropriate approach for a kind of routine kind of activities, data analytics, that sometimes support from the other side would not be useful. You need to sit with people, understand what are the challenges, work with them on a solution, present to them, discuss, go back. So it's like a kind of iterative, and it brings the solution that is appropriate because you are within the environment, you know what's going on. And sometimes some TA, I might say, get frustrated when you help someone and you don't see people either appreciating what you do or using it for the decision. I think seconded staff don't face that challenge because you know, this is, sometimes it's the wrong person, and you skip the head, you go to the officer, you work together, and the head gets the final product, and he's happy. He doesn't know what went into all this, but in the end, he gets he appreciates the work that is done. You helped me do this presentation. This was very nice. How did you do it? I know you, my staff, you can't do it, and you realize there is someone who has been behind the scenes. So I think when you are inside, you know how to play around the system and know where how to bring value to your work. But of course, with this approach, we need to have a long-term vision in mind. Otherwise, we might end up also replacing the people who were supposed to do the work. If I give an example, We have one expert in data management who is seconded to RSSB. When he came, we had an urgent need of developing a dashboard to track how fast we process invoices from the hospitals, because we had a backlog and sometimes inefficiencies were seen. We realized that the inefficiency, not in doing the work, but in, how can I say, an invoice is submitted through our branch and the branch keeps it for 2 weeks and they don't care what is happening in the hospital. So, and when hospitals are complaining, they're complaining to us, not to the branch. So they think we had the invoice. Without the dashboard, we couldn't see that. But with the dashboard, we said, okay, this is the date the invoice was received, but the headquarters have not seen it. So we acted accordingly. So that was an urgent need. But when we moved to the other scheme, doing the same, now this time the expert worked with our data team. They can now maintain it, they can now update it, they can now develop another dashboard. I can't say we don't need him again, we still need him, but at least we know if he's not around, someone can take over, but probably next year we'll be able to develop, they will be able to develop without his support, because now there's still that support and guidance. So that's a second approach. The third one is consultancies. It's mainly with the USAID projects. They like consultancies, and we, as the institution, we select what to submit to them because it's appropriate for one-time kind of event. You have a specific question, you want someone to do data collection and give you findings for you to act. So it works and complements what TA and secondment has. In other cases, we have the kind of multiple stakeholders in a way that I can call triangle. An institution either in Europe or in America that works with a locally based institution. I might say, for example, with the benefit package, we are working with the London School of Hygiene and Tropical Medicine and CHAI as a partner who is closer to us than London. And together, I think we form great teams. So sometimes things, and I can add, maybe it's not a triangle, I can add the University of Rwanda into this collaboration. So London School comes only when they are needed. There is a lot of work going on in the local teams, RSSB, University of Rwanda, and CHAI. And they only come in when it's needed. I think there is that transmission of knowledge across the teams, and we make sure that there is sufficient capacity within the country to carry on, even if the international partners are not around. So I think that's what I can say. Collaboration with academia, some of the work we do is research intensive, if I give the example of HTA. So we, from the beginning, know that university will be instrumental going forward. So, and we know there is no sufficient capacity in countries. So I think we are collaborating with the university now, but we know with 2 health economists and a number of research assistants, that's what the university has that we don't have. We have people ready to contribute scientifically as part of, it's a win-win, it's a part of the academic training, but also they get to contribute into evidence synthesizing from all the world. So they are happy with what they do. We are happy with what we get from them. But I think in the long run, I think my 10 minutes is over. In the long run, we need to, the long-term capacity building of the university itself, creating health economics programs. There is demand. They can see there is demand. I think it will be a win-win because we reassure them that it's not a kind of one interaction. We show them with the new instrument, a legal instrument on HTA. There is that clear visibility of the role of the School of Public Health and maybe School of Health Economics in the future in contributing to what we do. So I think that's what I had to say. In the future, we are starting a new internship policy. We think coaching as one of the approaches is instrumental. And when we saw what happened with research assistant, we thought maybe we need to optimize more these young people. When you are in school, no one will teach you around about what is happening in RSSB. So it's up to us to meet them in the school, tell them this is what we do, and it's beyond health financing. Maybe we also manage pension. You are a social scientist and economist, you don't know what pension is at the end of your class. So we want to get them into RSSB before they finish academia so that they can get interested when we publish jobs outside. Thank you.
Thank you very much, Dr. Hitiman. I think you've highlighted very, very pretty much practical things that you've done or that the country is doing in terms of trying to increase skill set on the continent, but importantly, your country. But you still you kept talking a lot about there are still few, and that's pretty much where the challenge is. We'll move on now to Malawi. What I want when we're talking about Malawi to begin to also think of gender issues, to also think about on the representation of different groups that have basically marginalized groups that you think within your context are relevant. Those kind of groups vary. If you're talking of South Africa, maybe race plays a card, maybe Malawi's ethnicity or less so, maybe it's something else. But in whatever context you have, let's think about that. So while we bring in the context of capacity building. So are we building capacity for everyone, or are we leaving some people behind? And why is that? So I would want you to highlight that, Kate, and again, highlight the capacity gaps that you have within the Ministry of Health. I know there are lots of health economists who have been trained in Malawi. Some of them are staying in the university. A couple others interact with the Ministry of Health. And what are the kind of gaps that still exist, the challenges, and how can we fill those gaps? So Kate, again, you have 10 minutes.
Thank you so much for that. First, I think let me talk about the capacity challenges in the Ministry of Health in Malawi. Listening to my colleague from Rwanda, I think our problems are not very different. For us, the problem starts with the labor market itself. As you said, we don't have enough health economists in the market. That aside, even we also have a problem when it comes to recruitment and allocation of these health economists in the system, especially in the health sector. What we have in the civil service, we have what is called the common service. So all economists are under the common service, despite of the field of study in the economics. Today, if you come to my department, I think you'll find more agricultural economists than health economists. It's because the way the system is. We have a ministry which controls the economic service, and they can transfer the economists anyhow to any ministry, regardless of the field. So much as we have a few on the ground, and you end up having those few being misallocated. And at the end of the day, some of them, they get frustrated and just go back to the university. So we really miss a lot on that. For us, like in the planning department, the skills which we need are mostly like health financing, health economics, resource mobilization, aid coordination, planning and budgeting. But this mismatch really affects us. So with those challenges, what are the opportunities which we have? Currently, I think most of the opportunity which we have to fill the gaps in the areas of the health financing or health economics in the Ministry of Health comes from the partners. We have the partners who are helping us to fill the gaps with their secondaries, or sometimes the technical assistants. And as my brother here said, the idea is to transfer the skills. But you see, in the end, with this high turnover, it's even difficult to transfer the skills, because probably once they transfer the skills, the person is transferred away. Currently, we have a few, I think 2 or 3 officers who are outside training in the field of health economics. But our fear is that when they come, are we able to retain them? Of course, recently as a ministry, we sat down and had a functional review where we created some positions which should be mainly departmental. Those positions are for the health economists who will be recruited by the Ministry of Health, and they should be retained within the ministry. Those positions we created deliberately so that they are not under the common service, so that it can help us to retain the skills which we need in the ministry. Of course, the challenge is that since those positions are few, it's also a bit of a demotivator to the health economists, because of the career progression, because it means they are stuck because the positions are few. Most of the economists, regardless of the field, you prefer to be on the common service, so that because it's easier, you can easily progress because the positions are many. So it's like it's a tricky situation. When you have those institutionalized positions, it's good for the system, but it's not good for the individual. On the other hand, with the common service, it's good for the individual, but it's not good for the system. So that's, I think, the challenge which we grapple with, and we are trying to see how we can resolve that challenge. Now, with the collaboration with the universities, what are the opportunities we see there? Currently, we are collaborating with KUHES, that's Kamuzu University of Health Sciences. There we have the Health Economics and Policy Unit. That's the unit which is also helping us to fill the gaps in the ministry. We do hold the think tanks where the policymakers and the academicians, we sit down to tease out the research questions within the sector, where we can work together in collaboration with the university to help us work on those research questions. It's really working very well. And moving forward with the assistance of CHAI, we are also trying to build the capacity within the university to make sure that they are able to train more health economics or more health financing experts who can help in the health sector. Now, the issue of gender, I think that's an issue which is common, I think, in most of the countries. There are some areas of study which, as a woman, you feel comfortable to venture in. You see, most of the women, we are comfortable going in these what people say soft skills. When it comes to the field of economics, most of us, we really shy away. So despite that, there are some policies on the ground to motivate women to go into the field of economics. We still have to work an extra mile to make sure that we have more on the ground. And then when we train them, there's also an equal opportunity policy, whereby if you have a woman and a man competing for the same position and they have the same skill sets, the same qualification, the opportunity goes to the lady. That's a good thing, but it also poses a challenge for the woman, because moving forward, you are perceived as if you are in that position because you were favored. So at the end of the day, you still have to work extra harder than the man to prove that I'm here because I deserve the position and not because I'm a woman. So we are still working hard to make sure that we push ladies forward. But as we are pushing ourselves forward, we also have to make sure that the skills and the qualifications and what have you are really considered to make sure that a lady is not seen to be there just to fill the gap just because there's a woman. Just just an example for like in my department, we have 6 divisions. These are headed by the deputy directors. And out of these 6 deputy directors, 2 of them are women. And me, myself, being the head of the department, I'm also a woman. So it's an encouragement for even the young ladies to see that there is an opportunity for a woman to rise to a higher position based on the merit and not just being pushed by being a woman. But as a country, we still have a long way to go. And I know that with this kind of collaboration, we can always sit together and help each other to come up with the solutions on how we can improve in building the capacity and strengthening the capacity in healthy financing and healthy economics in our countries. And by doing that, also making sure that we are encouraging all genders to participate and be equally recognized in the field. Thank you so much.
Thank you very much, Kate. That's very, very enlightening. You raised the issue of gender and the perceived affirmative action kind of playing out against women, which is something we have seen not just in Malawi, but many other places. Again, not just gender. It could also be race. It could, where such things play a role. If someone takes a position, they think that you're there as a woman because it's affirmative action, not for your qualifications or for your capabilities, which is a very, very big problem. And that's to layer on top of that the issues of child minding for women and how that impacts on their work and performance, and so they have to walk extra mile to, which is a big problem. But thanks for, excuse me, thanks for raising that. It's something we'll have to begin to think about. Let me move the floor now to home, South Africa. So you're going far to come back home. We have 2 distinguished panelists from South Africa. We have Sheetal there, and then we have Vishal, who will take turns, about 10 minutes each, to look at 2 different aspects. Whilst Sheetal will be looking at from the academia, since she's sitting at the University of Cape Town. So we want to know more about how academic partners and people who are within academia and research generally can support government policymakers, whether it is through technical analysis or embedding researchers in the Ministry of Health, or how that can happen to strengthen capacity for health economics, health financing, and even health systems analysis, not just health economics, but things that can help move the health system forward. So when we talk a lot about the health system, it's important to talk of the complementarity of fields. It's not just about health economics, even though we are focused on health economics because we are health economists. So Sheetal, you talk about that, then immediately we can hand over that to Vishal, who will again begin to talk of experience within of health financing and economics within government circles. So now we have a policy maker, someone in the government circle, speaking now heart to heart with someone from the academia. So you both have 10 minutes each. Thanks.
Thank you, John. I did have some slides. I'm wondering if they would come up and where I would control them from.
Pardon me, never knew. Yes, they're going to shoot the slides. I wasn't aware. Thanks.
Thanks.
Can you present from there, or you want to?
It's a bit weird.
Okay, whatever makes you happy, I'm happy, and I think we're all happy. Yeah, good. Yeah. Good, pleasure.
Morning, everyone. Thanks, John, for the introduction. So I'm Sheetal Silal, and I'm actually not a health economist at all. I'm an infectious disease modeler, and I am the director of a disease modeling institute at the University of Cape Town. But of course, when you're doing your modeling for policy, so at the interface of science and policy, we have to work with health economists. And so part of my unit, we employ health economists, and we work with health economists all around the world as well, in order to translate our model findings into costs and benefits, and thereby be supporting effective policy decision-making. And so what I'd like to talk to you about today is something John alluded to in the beginning, which is trying to get people from with skills, health economic skills, or adjacent skills like disease modeling and so on into government. And in South Africa, we approach it, I think, in a slightly different way, and a different model is emerging as being successful for us. And that's something I'd like to highlight today. So in South Africa, we come from two bits of our background I'd like to talk about. One is that we do not attract a lot of postgraduate students. These are not, we don't have large numbers and droves of students after one finishes school, getting into university, finishing an undergraduate degree, and then coming into postgrad. Postgraduate study in South Africa is a privilege. And so when we have such a small number of postgraduate students, to then embed these students into government, that filtering process with the attraction of the salaries offered in the corporate sector or the private sector, we will find very few graduates being employed and retained in government. And so we could either just try to increase those numbers and hope that we will have sufficient capacity in government, or we could try for a different model. So that's the one aspect that I'd like to present on. The second aspect is we are lucky in South Africa to have a very strong history. It's not always perfect, but a strong history of government decision-making that incorporates both health economics, disease modeling, basically scientific skills. We have rich scientific capacity in country, and through the scientific representation in various advisory groups, NITAGs, and so on, being comprised of people from academia, health economists, disease modelers, epidemiologists, and the like. Along with advisory groups, we have successfully conducted major investment cases that have led to long-acting successes in South Africa. For example, the HIV investment case, the malaria elimination investment case. And because of this continuous interaction of scientists from academia and government, we have a well-formed relationship already in place that has allowed even governments just to come to us quite naturally when crises emerge. And of course, the COVID pandemic is exactly one of those. As disease modelers and health economists, we didn't go to government to say, hi, we exist, we'd like to do this for you. Government called us to say, oh, can you develop a model for us, please? And we would then move ahead. So such was the strength of our relationship. And so with the COVID-19 pandemic, we formed in South Africa the South African COVID-19 Modeling Consortium. And in that consortium, we were a group, not just one academic institution, but a group of academic institutions working directly at national, provincial, district, several levels of government for a period of 2 or 3 years. And so with that strong relationship now becoming quite routine in a period of 3 years or so, what you have now is a position that we can leverage. And so the pandemic has now allowed us to leverage this strong relationship because government has recognized the level of analytical skills in academia. And so we said, well, instead of training more and more students to have just a few working in government, why not work with this partnership to have this continuous flow of interaction between government and academia? And so sometime I'm trying to go next here. Could you do it for me, please? Next slide. Am I meant to point somewhere? There we go. So lots of text, but just to explain it briefly, back in 2021, we established throughout the COVID pandemic a very strong relationship with CHAI, and in particular the CHAI South Africa office. And in 2021, my group, Masha, we fostered a relationship between CHAI South Africa office and the Department of Statistical Sciences at the university. And what we were trying to do is to say, you know, there are numbers of government data sets, and often what we in data science call big data, existing in government, languishing for analysis without any capacity in-house to do such analysis. There were areas where we could analyze large sets of data to help support efficiency and support sustainable finance. And so we fostered this, or worked with CHAI SA and the Department of Statistical Sciences at UCT to create a data science fellowship program. And what this fellowship program does, next slide, please, is that it allows our master students who have a 2-year degree. Their first year is their coursework. In their second year, they're looking for a project, a thesis to be writing. And so through this relationship with CHAI, we allow the students to be working on a government problem, a problem within government that would support efficiency. And most of our projects sit within the sustainable public financing realm. And so the students then work on a project that is real data. It exposes them to what working in public health is. So they don't have clean academic data sets. No, they have the full lot of raw data coming out of government that requires every bit of analysis, several forms of interaction in order to be able to analyze and feed back to government. And government gets some analysis and some support, some evidence to support decision-making for free. So it's very much a win-win situation between the university's academic partners and with government departments. Next slide, please. And so this becomes quite a collaborative affair where we have interaction with government. CHAI we have a supervisor within CHAI and a supervisor on the academic side. I'm going to skate through very quickly so you can just keep going, just to highlight a couple of projects. So we've had projects so far on looking at anomalies in lab test ordering. So a student had 23 million records of lab testing data and had to filter through all of this data to understand, is there over ordering in the system? Are there violations of benchmarking? And so this requires quite high analytical skill, as you can imagine. This student, Kaylin, for example, she used a discrete time event multi-level survival analysis and machine learning in order to analyze the employment data set in the Eastern Cape to measure and provide a better estimate of attrition rates. Another student, this is quite a project I'm really interested in, he's about to submit. Sky built an agent-based model of the emergency health services entire system of ambulances and calls and how response time is being managed between different priorities for the Eastern Cape to identify bottlenecks of underperformance so that we can make a set of recommendations to the government. As part of his project, in order to understand the data better, he himself went down to the Eastern Cape and was capturing data from handwritten books and so on, just to get an understanding of where errors in data due to human capturing were occurring and so on. This student, for example, was looking at case mix and coding errors with the diagnostic risk group assessments in the Western Cape. Thank you. That's the 2022 cohort. So that's our first cohort. This year, we have several projects. The solid bullets are for the data science students, and we also now have a relationship with students in the health economics unit at UCT, and those are the bottom 3 bullets as well. Just highlighting a few projects. One of the students is doing using tracker data to assess fuel theft and irregular vehicle utilization. Now, if you can imagine the size of that tracker data, you can see that we are going beyond a standard level of analytical skills. And the students who have this training, who would ordinarily be doing these types of projects for the private sector, are doing them for the Eastern Cape in South Africa. And so another one is looking at an optimal allocation algorithm for condoms in South Africa, investigating the association between what an ideal clinic program looks like and other measures of performance to see if this ideal setting actually does improve or signify a better functioning clinic and so on. So we have a range of really exciting, quite diverse projects that do require different skill sets. And this would very clearly not ordinarily be able to be completed in normal government function and government time, but with partnership through the universities, we can do a whole lot more. And so as I end off, I'd like to also highlight something else. A point John made in the beginning was we train our students in order to be readily available to be snapped up by the markets outside of the continent. And baby will soon be a student too. So I want to raise a point then. I want to talk about a different program, and it's not a health economics training program. It's a program I'm leading at my unit. It's a Bill and Melinda Gates funded program on developing PhDs in disease modeling. There are very, very few disease modelers on the African continent. And what I'm doing is not a South African project, it's an African project. I'm training 10 PhD candidates or rather 13 PhD candidates from 10 African countries. And they're training in South Africa, but what makes this project quite so locally created and locally driven is that we have established partnerships with each of the country's ministries of health. And we work with advocacy partners and universities in each of the countries to be supporting these students. So they are being trained not just as technocrats, as scientists, they're being trained as policy-facing modelers. Some have health economics projects, others will be using health economics. Certainly they receive the training as well, or working with health economists. But this is now at the interface of science and policy. And the reason it is already becoming such a successful program is because it is an African-driven initiative. And if you want to create the talent and capacity to be situated in our continent, we need to train these students to be customized and tailored their skills for the continent. So in ending off, capacity building is absolutely essential for us to be leveraging and sustaining our skills. And as John mentioned, we don't need to train in just one field. We don't train in just health economics or just in mathematical disease modeling. We need to train in the system-wide field so that even as a health economist, you realize you don't work in isolation. You have to work with epidemiologists, have to work with public health specialists, and so on. How do we do this? Well, we want to maintain this pathway to impact. We could do the traditional, let us train PhD students, let us train master's students, and that's a long-term sustainable approach. Great. But there are things we can be doing now. We could be doing some non-traditional things, like with part of my cohort of disease modeling students, each of them as part of their degrees will be seconded to their ministries in their own countries to spend a period of 6 months to be working, showing the ministries what their skill set are, and also supporting and understanding what it is to work in public health. We can establish partnerships for active mentorship, leveraging relationships that are already established. We can offer long-term courses for decision makers, not just your fly-by-night sort of workshops where people engage for a few days and then forget about it afterwards, but long-term participation. There are a number of ideas we can come up with if we put our minds to it and understand the systemic, sort of the system in which we are actually operating. So with that, thank you very much. And over to Vishal.
Thank you very much, Sheetal. That's very insightful. You know, she was a bit modest there. She started her career within the health economics unit. So in a way, she is a health economist. She didn't want to talk about that. So Vishal, please, can you take the floor?
I'm not sure where to start after that, but I also had the slides, but I'm not going to use it anymore. Even with the mic, I still mumble, right? Okay. So I think there's 4 points, and I don't want to belabor what's been said. I think the first one was we started almost 30 years ago. We were blessed in South Africa. We had a local capacity to do something, and so there was, when I look back at it, at the time when I looked at it, it was a well-structured, it looked like a good program, well-structured. Had a local, it was locally entrenched. There was a partnership between academic institutions, including the London School of Hygiene and Tropical Medicine, government, and donors in the EU. And the first round of health economics interns were actually sent to the London School to do the masters in health economics, financing, policy, something like that. And then we had a group of people that came after that through a capacity building program. So some of you might know the name Professor Lucy Gilson. She was seconded from the London School out to WITS, Center for Health Policy initially, and then and now she was my supervisor and mentor at the time, and she was not a health economist. She was I think she barely said she was an economist. She was a social scientist, political science. That was what her field was. But what we started to do was we started to develop a number of individuals over a period of time. So it was a 2-year internship program. You would go through various research projects. These projects would be funded by the National Department of Health through the EU grant. Over time, we changed it slightly, and one of the speakers on the conference on the last day in the closing session, you'll probably hear of a person called Martin Henscher. Well, it's now Professor Martin Henscher. And I changed the program. We actually started to move away from just funding universities to actually developing in-house capacity as well. So what we would do is we had an internship program with 3 universities, UKZN, UCT, and Wits University, where there were 2 senior researchers, 2 junior researchers. In the national department, we hired 3 researchers, and we started to use them to do basic things, costing work, all the things that policymakers and technocrats in ministries don't like to do, primary data collection and literature review. So we got them to do all of those things. But in doing so, you actually learn how to do and take things forward. The challenge, and it comes to the next second part. So the individuals that came through the pipeline, one individual went on to be the chief executive of the Council for Medical Schemes, chief executive registrar. The other one became the CEO of the South African Social Security Agency. I guess I'm the black sheep in the group. I mean, we all 3 were the directors of the health financing unit, but that was where I kind of like stayed, and then I joined CHAI. That was the end of the trajectory. We went to a process whereby the funding came to an end. And as the funding came to an end, 2 things happened. The relationship with the universities fell away. John, it was about the time you came into it. The second thing that happened was the people in the unit started to move. So when I left the unit, there were 8 people that are left behind, technical people, and a secretary and an administrator. Within 3 years, it was down to a secretary and 1 person. What happened? Well, it wasn't that people weren't interested, but government wasn't interested in filling those positions after they left. Secondly, because we actually stopped the internship program, there was no pipeline. There was no interns coming through. In the first few years, virtually all of the interns got employed by government. We would create positions in government for them to be absorbed in some. And so when that happens, it stops. It stopped because government didn't continue funding it. The EU funding stopped. There was a space. When we look at the issue around capacity building and capacity filling, I think that's actually a very important one to understand, because we're not actually looking at sustainable structures. And if we don't develop structures that are owned by government, it's not going to be sustained. It needs to be government funded. It can be augmented by support from organizations like CHAI and donors like Gates and other organizations. But It actually needs to be owned and founded within government structures. And the problem is that you also come to the second part, which is what Sheetal mentioned, which is, the distinction between what people are trained in and what they end up going and doing. Health and economics, not health economics, health and economics don't really go together. So when you get trained in health economics, and John likes his models and economic evaluation techniques, you go into the Department of Health in Pretoria, and they ask you to go look at a budget. And you ask yourself, what am I doing? So understanding public finance and public policy is actually more important than some of the models and things you build. But you need to understand how to use data. You need to understand how to interpret information. And so I think the question to all of us is, are we training people to support government needs in positions that are needed? So if I look at South Africa and NHI and implementation of NHI, there are not many people that question the principles of which it's based on: universal health coverage. We need to get people onto treatment. What they're not sure of, and they're really concerned about, and the anxiety shows in different ways. We don't know if government's got the capacity. We don't know if they know what they're doing. And sometimes the way in which government communicates and shows outwards, you just start to believe that. And I think that's what we need to change. But you only change that by having people that can do things. Sheetal's program around big data science and big data sets, emergency medical care and transport. Let's move to DRGs and capitation contracting and see how the data points start to increase exponentially when you start looking at those things. You look at one of the major voluntary health insurance administrators in this country. They've got a team of more than 30 actuaries working. They serve 4 million lives. And I'm not saying that we need that kind of structure to support 60 million, but we're going to need a lot of people. But we need people who can understand and dissect and analyze information and provide policymakers with information that they can take decisions on. They don't need to always have to do it. And the modeling consortium, we'll have another conversation one day. Nikhil stepped out of the room, but it's interesting to know. It's interesting about who you know, as opposed to some of the processes. So, senior official at Treasury called me, said, I received this report from some institution. They say that half of the population is going to get COVID. More than a quarter of the population is going to end up in hospital, and about 6-7 million people are going to die. Surely this can't be the case. What do we do? And so we bashed a few heads together, and we came and said, let's put a consortium together. And her name was one of the first ones to come up, mainly because we worked with Sheetal on malaria work in South Africa. So we knew her. So the treasury official knew me, I knew Sheetal. Groups started to come together. But it can't just be a coincidence. It can't just be about whether John knows somebody in Ghana, in Malawi, and Rwanda. It's got to be about whether they are a sustainable process. The last part is, I'm going to use the health economics unit as an example. Di McIntyre was the director of the unit 25 years ago. She took a view back then that if she continued to be the sole person running the unit, there would be no capacity developed to lead the development of health economists in the future. And because of that, we have trainers that can actually develop new students. Without it, we would have been stuck. So if the internship program collapsed and we didn't have people with vision like Di at the time, we would have not had the program. So 30 years ago, we've been great. 25 years later, we've been useless. And that's unfortunately how it happens if we don't support each other in the processes. And I think, let me stop there, John. I think that when we look at the way forward, I think looking at the way in which we align skills, not just health economics, but skills, with what the needs are, and what the policy reform processes in countries are. So if we're going to support the Department of Health, if we're going to support the Nicholases of this world, then we need to give them the people with the right tools so that he can be comfortable that what decisions he takes are the right ones.
Thank you very much, Vishal. You raised very salient points there, which we'll come back to. I will quickly invite Dr. Miraf to take us through Africa CDC. She would introduce what Africa CDC is, and she will do it better than I will. So Africa CDC is a program that sits within the AU structures. They currently have a health economics program, and she's one of the team members. And we want to also know the kind of vision and activities that the Africa CDC, or the health economics program, has in stock in terms of capacity building and strengthening for health economics, health financing, health systems analysis and research on the African continent. Right. The floor is yours. Yeah.
Thank you so much, John. Yeah. So the Africa CDC, it's still relatively new, I think deserves a couple of sentences as a way of introduction. So the Africa CDC is a public health and autonomous agency of the African Union with a mandate to safeguard Africa's public health, basically covering all the 55 member states. So the vision is basically to create a safer, prosperous African communities for a flourishing life, right? So the health economics program within the Africa CDC was established still very, very, very new. So 2.5 years thereabout. Basically to support both Africa CDC itself and member states to be able to generate, use, and deploy health economics and financing evidence to, improving the decision making. Why? Because we believe that with such ambitious goals and the immense resource scarcity, there's a need or there are several additional values that health economics and financing tools could bring to the table, right? So that's why we have a health economics program. Someone yesterday asked me why a CDC is involved in health economics. So that is basically the rationale. There's a lot disciplines can bring into the decision-making space. And then how do we do that, or how do we achieve? There's a vision. Basically, we work with a three-pronged approach. We call them pillars. The first is capacity building, basically for health economics and financing on the continent, but also within the Africa CDC. And the second is evidence generation and synthesis, basically to bridge the gap in evidence availability. And the other element is promote use of this evidence through engagement of policymakers. And one of the comparative advantages we have as the AU agency is our convening power to involve high-level decision makers, right? And as you all understand and know, nothing happens if the head is not involved. And so in implementing our activities, one of the principles that guides our engagement is basically we target multi-level actors in the process of building capacity for health economics and financing. So if I zoom into the capacity building pillar of our work, within the Africa CDC, there are some, initiatives or fellowships that engage heads of states and ministries of health and ministries of finance and high-level senior government officials, basically to build their capacity and create awareness on various fields. And one of the core components of that is health economics and financing. For example, and then there are some initiatives that we, the health economics program, initiate to engage with, leaders in the field within member states ourselves. So, for example, in some of the initiatives, if I mention some of the initiatives that the other divisions work on which we also get to contribute to, there is a coffee and fellowship program that Africa CDC runs, where we have a module. Basically, it targets senior level government officials to build their capacity in leadership and so on. So we get a module there to basically introduce the concepts of health economics and financing, to create awareness and the added value of using those tools in the decision-making context. There's also a ministerial executive leadership program, which is coming up in a few months. We're also working with a team coordinating that aspect of it, basically targeting the ministers of health, not only on health economics, but overall leadership. But health economics and financing is one area which they identified as one of the topics they want support with. And then some of the initiatives in our own division or in our own program is just last month we had a training workshop for Director Generals of Policy Planning Directorates of Ministries of Health, basically to introduce the concept of evidence-informed priority setting and health economics and how it applies to benefits package design. So, and then apart from the higher level and mid-level decision makers, we also have initiatives targeting, individual level experts. So basically multi-level from high level decision makers to individual level. By the individual level, at the individual level, we use we were talking about earlier from my colleagues about the relevance of using mixed approach, right? Not just technical trainings, hands-on technical trainings, but also opportunities for them to, see how the actual policy environment looks like from within. So we have, training opportunities on economic evaluation and related fields. And as I mentioned, how a benefit package design is the process of benefit package design is handled. Apart from those technical trainings, we also have mentorship and coaching opportunities for early career researchers. In fact, John is one of the participates in one of the early career mentorship programs where we have early career researchers from African countries mentored by people, experts experts in the field from the continent itself. And then we have opportunities for internship opportunities, basically to help researchers and early career practitioners to see how the decision making or the policy environment or the actual work looks like. So as we speak, we have a PhD candidate sitting with us in the department who basically involves with everything that we do. And we are receiving 2 more interns from Monday. Today's what? Yeah, Sunday, right? To tomorrow. To spend, a portion of their master's program with us to basically understand how the real life looks like, right? So not only just, building the technical skills and rigor, but also to give them the context on how things look like. And then as we do the individual level capacity building, we strongly believe that in as much as there is a gap in health economics and financing on the continent, we strongly believe that there is also capacity which we can tap into and use as a yeast to basically further develop the capacity needs and gaps on the continent. And so we, in as much as possible, use local experts in all of the engagements that we have or that we support countries. For example, in 2 of the member states, we are working towards establishing health economics policy and systems research centers, which basically links ministries of health and ministries of health and academia, universities. So basically local universities using local universities to build the capacity of people in the Ministry of Health to get the right skills in this field, but also within the academy itself to identify and train master's, PhD, and postdoctoral fellowship programs so that we can slowly but surely build the critical mass of trained professionals in the field. And currently, the way it is now is the focus is on those countries, but the vision is in the coming 3 to 5 years, those centers will evolve to and become, hubs, which will now support the capacity building efforts in the coming in the region in the coming few years. And of course, we also believe in partnerships. So we have technical partners and academic partners, both within the continent and outside. We work with professional associations as well in all of these engagements. In the benefits package workshop that I mentioned, for example, we worked with WHO, CGD, University of Bergen. In the other initiatives, we also have collaborations with Harvard, NIPH from Norway, and the professional associations within the continent, AFIA. And the last point, I think, is that we also, in addition to building individual capacity, we also have kind of multi-dimensional approach where we also work on the policy environment, making sure the policy environment is favorable for uptake of evidence and as well as institutional capacity building in terms of, modeling approaches and so on. So yeah, I think that's briefly what we.
Thank you very much. I mean, we've heard from a diverse panel. And if you take a look at your time, you see it's a little past 10. We kind of running behind time. We started a few minutes late. We tried to catch up, like a pilot will always tell you. Don't worry, we'll try and catch up with you. And it never happens, just to keep you at ease. But it's not like the pilot who once said and welcomed everyone onto the flight and said, ladies and gentlemen, welcome on this flight, blah, 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 blah. All these funny things they say. And then at the end of the day, she goes like this, but unfortunately, I don't know where we are. You know what that means? If a pilot tells you don't know where, but fortunately for us, we know where we are. It's time for lunch. Sorry, not lunch. You see, that's why we don't know where we are. You see, great. You see, you see, we don't know where we are. So it's time for tea break or coffee or whatever you want to have. So we will try to. The reason why we have to break for that is a fixed point that cannot be moved. Economists will understand that. It's like a fixed point. So it's a fixed point that cannot be moved. So if we can break and then come back, keep questions. In case you forget, or in case you think you forget, you can write it down so that we can take a quick round of questions before we continue. We'll try to be brief before we continue the program. I hope that works for everyone. I like democracy. Good. Yeah, because we've been sitting for a long time. So a round of applause to the panelists. Thank you. So we'll be back at 10:30. Thanks. So that phrase is very common in Nigeria. When you hear share money, yeah, it means a lot in Nigeria. So we have one person missing. He has another panel. He's in hot demand. You see, our panelists are really top notch. They are all in hot demand. Maybe the next person to leave, it goes like that. Kate might go next, and Masha, and Shital, and then it goes up to the last. We've heard a lot about capacity strengths, capacity gaps, what different institutions are doing, and we've heard from Malawi, from Rwanda. We also heard from South Africa, and a general overview. in terms of Africa from the Africa Centers for Disease Control and Prevention. You may have questions that you've jotted down or you're still thinking. Feel free to pose the questions, then we'll pass them to the panelists. Yes, we have a hand up there from Collins, Chancellor. Please, you can just introduce yourself. Let's know who you are, and then.
Okay. Morning. My name is Collins Chancellor. I'm a senior economist at World Bank. I just wanted to reflect on capacity. I don't know. Maybe I didn't get it because I was a bit late. What it really means by capacity? Are you talking of the numbers or some inadequacy in certain skills? And I very much like what Vishal talked about with regards to aligning the skills to the needs. So in that regard, do we really know what is needed? Because listening to the discussion, I get the impression is that we're talking about the numbers, not really what is needed. And also looking at the Marsha, I mean, a lot of good work is being done there. But in terms of the impact of that, I don't know, have you followed up with regards to what has been done? I know when the economics unit started, I think I'm one of the beneficiaries. I think the design was more with regards to what Vishal was talking about, not really a strong emphasis on health economics in inverted commas. There's a lot of evidence-based medicine, epidemiology, health policy and planning, and health systems. And that worked, and most of us went back, and then we delivered. So I don't know if you've looked at how it was before, because that is what all the other institutions, universities used to love about the program and the like. So I don't know what is missing now. I think that would be important. But I think the decision space, John, you argue about capacity, but having worked the Ministries of Health, I think probably what misses is the decision space for the graduates, for the health planners to be able to make those decisions based on what they've learned. So I don't know how you're linking whatever skills you're talking about through, for example, what we talked about yesterday. I don't know if you joined the session on the health leadership Ministry of Management, where talking more about advocacy. I think for me, what lacks, of course, there's an argument for skills, but more so, I think the decision space. I think for me, I'm what I am because I was given that space to do whatever I want. And if we're able to advocate for that, I think that will actually move the needle forward from the skill itself, and also having that space to be able to use whatever skills which have been applied. The last point is on mentorship. I know it's good to go to school and then get the skills, but again, what does it help? Like I know in Malawi and Zambia and other countries, even Ghana, we have this health finance integrated working groups, and those help a lot. So what sort of formal and informal capacity or mentorship programs are there for this capacity to be continually refreshed? Because the health economics world is evolving. So I think that's also what we could look as well.
Thank you. I'll take, you can take the questions. It's better to have jot down the questions. We'll take more if there are. Okay. Yeah, there is. Thanks.
Good morning, everyone. I'm Ashur from Nigeria, work with Clinton Health Access Initiative. I think the conversations are quite insightful, and they made me kind of reflect the trajectory I followed. In 2016 or so, when I went to do my master's in health economics, I knew right from the beginning that this is something that I need to have as a medical doctor. I mean, the wants, unlimited wants, the limited resources, I think makes a perfect case for anybody within the medical field to attempt to pursue health economics. But when you go into the university, the school I attended then, you realize the teachers are purely economists and don't have any touch with health. And their thinking of you is you're coming to this space only to get the certificate. And so they cannot appreciate the theory they are passing on to you. What relevance will it make to the system? On the other side, from government, I'm not sure, maybe within the system and the agencies that we work, there's anybody that I knew with health financing background. And those that, we've done the courses together, they can only function in as much as the appetite is there from the political leadership. If the need to get the evidence is there, then you can work. And that's why I liked so much the collaboration that we had, in South Africa, in Rwanda, in 2013, Dr. Agnes, we met in Arusha, and was saying when she came at the Minister of Health, she ensured that whoever will work with her at the ministry had at least a master's degree. And that's because the appetite is for evidence-based decision making. But if you get political leaders, chief executives that are only there for the politics, and all they want is to ensure that we maintain our seats by hook or by crook, they will not be able to take these difficult decisions and say, okay, Your Excellency, we need this for this value. Because for politicians, it's just about the political currency. Is it good for the optics, yes or no? And I think these are all conversations that perhaps we need to factor in to ensure that this capacity building is sustained. And I really hope that we will be able to take this conversation, especially in our countries, that how do we help to do this blended approach? The government going in to do some sort of career guidance for students studying health economics and what have you, to say these are the opportunities that you stand to do. Can you come in for some internship, some postings within government structure, so that as you are coming, you understand the government needs and you'll be able to fill in those needs with the right knowledge that you are getting. So I think this is quite an insightful, and we hope that we'll be able to take some of this back home to see how do we get this partnership established and get some tangible results. Thank you.
Any other question? Okay, that's one here.
Thank you so much. I think it's really informative. So maybe for from country's perspective, it's really great to
Can you introduce
work.
yourself first so that we know who you are?
Yeah, Elias from Africa CDC, Ethiopia. So country perspective, what's the role of the National Institutes of Public Health, or like some countries, they may call it CDC? We know we need to collaborate with academic partners, with policymakers, but still there are technical agencies within countries which they need to be involved with. So, I mean, it's really great to have that lesson, especially from South Africa, to have that link of those students. But what about with the National Institute of Public Health? I think that's one idea. And the other one is for the continental-wide approach. I think it's really great to have a clear roadmap and continental way of doing things, especially from policymakers, academic or professional associations, and plus partners. So I think there was an initiative to especially Africa CDC, AFIA, and SPARC. They did it in September last year to have a clear roadmap of doing things at a continental level, so that who does what in a different space. So I think that initiative need to be, keep going. It's just a reflection on that one. Yeah, thank you so much.
Okay, thanks. Let's give the panelists a chance to answer before we all respond. Not necessarily answer, but it's a discussion. I don't know who wants to go first. And I think ladies should. This is a very balanced panel here. Sorry, Vishal, you've been sandwiched. Okay, Masha. Well, why do I always call you Masha? Because of Masha. Okay. You go ahead, Shita.
There we go.
Yeah.
Thanks. So I'll respond to a couple of points. So on the first point of capacity that was raised, what is the kind of capacity we're trying to achieve? I think we've got to look at that in the context of what allows you to build this capacity in the first place. And I'll give you two examples from what I presented earlier. For our data science program, we're doing this program with all of those projects in a very much unfunded way. We have a minor stipend that we can offer the students. We're not paying for their degrees. They have to already find their own funding to be registered first, and we then support them in their second year because we have no external funding at the moment. We're writing pitches and trying to get more funding, but it's done in an unfunded way. But in contrast with the PhD program that I described in modeling, because that is Gates funded, it allows us to build capacity in a much more systemic way. That we're not building the person only by saying, here are some new skills. We are offering capacity building in terms of, let's offer leadership program. Let's offer supportive money in the sense of if someone is sick, then we can help them by with medical insurance. If they need care from a family member, we can provide that in order to help them become to help their learning experience be a better one. On the other hand, we can also offer grant writing skills, scientific writing skills, research entrepreneurship skills, helping them to chart out their careers. And we don't just offer on the technical side mathematical modeling training only. We offer health economics training, epidemiology training, evidence-based clinical medicine training, and so on, as was described. So it's about, if you're going to be operating within the health system, you need health systems training, and that's the basic principle of the academic program that we offer. And I apologize that we didn't get to explain the whole list of partners with whom we work in our in the data science health economics program. But the NICD, we call in South Africa National Institute of Communicable Diseases. It's similar to the organizations that you highlighted. They have a very clear role in our partnerships as well, because they are the managers of health data. So if we're pursuing health problems, though we might be pursuing them on the economic side, they have to be a key partner along with the decision-making partners as well. So we engage with the whole spectrum of key partners. Thanks.
Okay.
Just to say a few words on the decision, the importance of doing something in the decision space. I think I totally agree with you. It's not about the skills, having large volume or number of people with the right skills. The environment, the decision-making space, and the policy environment needs to be favorable to be able to benefit from whatever skill is made available. And as I mentioned, one of the comparative advantages we have as a EU agency is basically to engage the high-level policymakers, which may not be easy for other partners in the space. And so we have various platforms, some of which I mentioned earlier. Basically, the idea is to introduce them to the concepts and the added value of using these kinds of skills, bringing those skills in the decision-making space. But of course, we all know that the decision-making is more political than technical. So, but slowly we can inject those concepts. And then as we move forward, hopefully there will be more openness and, utilization of evidence from our field.
Quickly talk about the issue about mentoring and formal and informal mentoring. And it's fortunate that Alex walked into the room after tea. He was one of the people that was my supervisors when I joined the Center for Health Policy. And he served as a mentor, not just to me, but to others. I remember during the medical schemes amendment days, Patrick and Alex just spent a lot of time talking and strategizing and figuring out what needs to happen. So when you sit in a specific role, and even till today, I still have these. So there's individuals like Di, Lucy, Alex, who I've grown through the system with, that I still go back to. And sometimes you just want a sanity check. You want to be able to know what you're doing is correct. And sometimes you want to know that you don't do certain things. So it's important to have people like that you can keep calling on and being able to refer to, no matter what your level in the system is. Because you don't always have all the skills, you don't have all the knowledge, and sometimes you sit in an environment where you're fighting fires, and that's your job, and so you can't see the tree from the wood from the tree. So it's important to have those structures, and I think we don't pay enough attention to the mentoring and the post-training mentoring and supervision that needs to happen.
Thank you. From the ministry point of view, when we talk about this capacity for us, it's much as we talk about the numbers on the ground, we are also looking at the right numbers with the right skill set. And then there is an issue on how we balance it with the academics. One, we have also, as I said, we are working together with the academia to make sure that they produce the right skills which we need on the ground, because that's also another problem. And once they produce that, how do we get those right skills in the system? Which brings us to the issue of resources. One, we have a problem to make sure that we have the right numbers trained. As she said, they have the skills to transfer. They can train, but for the people to be trained, they need to be already funded. That's another problem which we have in the ministry. To have the resources to mobilize enough resources so that we enable people to get the training which we need on the ground. So at the moment, it's like we rely on the partners. There is no proper systematic training of the health economists. So we rely on the ad hoc partnership with the different partners to help us with the resources to train our people. And as I said earlier on, the other problem is that even when we get those resources from the partners and we get those people trained, it's not a guarantee that those resources will come back to the ministry to be used there, because the recruitment system is another thing altogether. You end up training people, they come back, and then they are deployed to another ministry, where that means, yeah, you are losing out. So we are trying to find a balance on how we can have the right people, the right skills, and then those people being available on the ground to really do the work which they have been trained on. There's also, as I said, we have in the ministry established the positions which are departmental position, where we want to fill these people and they cannot be transferred elsewhere. Now another problem is even to find the resources to recruit, to fill those positions which we have created. You know, with the little resources in most of our countries, we have competing priorities. When we request for recruitment, like for the health sector, what they see as the critical positions are the frontline health workers. So you can easily get resources for the frontline health workers to be recruited, but for the planners, for the health economists to be recruited, that's another issue. They don't see it as a priority. So I think it's also for us in government as policy makers to be able to sit together and tease out these problems, to make sure that we all understand in different sectors that we have also these skills which are really needed on the ground. So we, of course, have these platforms like the TWGs, where we convene stakeholders from different sectors, like the finance, the Department of Human Resource. But I think as a health sector, we have some way to go to make sure that we have this really this plea heard to by everybody to for them to understand the importance of health economics in the health sector. There was, I think, an issue to do with the role of public health institutes. Yes, we have a public health institute in Malawi. It's called FIM. It's currently it's within the ministry, But we are also working hand in hand on these issues. We sit together in the think tank where we have all the policymakers in the ministry sit together with the academia to look at the critical policy and research issues which need to be worked on for our easy decision making. Thank you so much.
Thanks a lot. Very good responses there. The one I was kind of missing through was the issue of numbers versus Collins talked about. When we talk of capacity, are we only talking about numbers, or we're going beyond numbers? But it's kind of touched on as you presented going forward. But let me pose a question. Vishal talked about having a senior mentor in our midst. I'm going to put him on the spot there. Professor Van der Heever is here. From your own experience being a mentor, and we're looking at challenges of pretty much not just numbers, but capacity building of health economists on the continent. What are the innovative ways that you think we could begin to look at to build the capacity of health economists on the continent?
Yeah, it's a very difficult question because on the one hand, you've got to have an assumption of the decision-making structure for which health economists are slotted into. And there's one model, which is government on a top-down makes all the decisions, and you're training people to be working for a government department who's helping them to appraise their policy options. But in reality, that's not how policy is made in many societies. In many societies, policies are dialogue, and therefore the capacity that is being generated is not just for a government department, but for society as well. And so you've got a diaspora of capacity that can engage intelligently on technical conversations about policy and choices. So I think it's, so you've got to, so on the one hand, there's a training people with this kind of capability to be able to engage. Then there's the model of organizations that are looking for capacity in their organizations. I mean, I grew up, my father used to run the Maths Olympiad for Old Mutual, and they would award all the gold medalists fully paid bursaries to be actuaries. And they would pay for everything, and they would work part-time because they were creating a resource that insurance companies need and build it in. That model still continues today when you've got highly prized technical capabilities essential to your organization. You don't leave it to chance, but that's an organizational response. There's still the response, which is societal. So I would say it's not one approach, but the career path is important to how people decide what they're going to do at a university. And if there isn't a clear career path, they choose something safer. So the problem is in a social discussion and engagement, there isn't a clear career path for many. And if you look at health economics in certain universities in the UK, where they're giving programs for economic appraisal, 10% will be there on nice bursaries, and the rest will be from the pharmaceutical industry, telling you about how the conversation is going. And it's basically an arms race using technical work as a basis for making decisions. So it's not a straightforward answer.
Yeah, that's a very, very good point there, the murky waters. Yeah, any other question, inputs? Yeah, okay. Can you introduce yourself?
Thanks a lot. My name is Dare Bodurin. I am the immediate past lead for Strategic Purchasing Africa Resource Center in AMREF. And thanks for this conversation. I think it's personal to me, but also very important in my last role. And there are just two reflections, and I think some of it have been made already. One is, are we training for the need? And I'm going to share from my personal experience as a lead for many health financing projects, at least in the last 8 years. Every time I recruit a post-grad health economist and I interview, what I hear from the interview, the questions I ask are, of course, based on what I need, and my need is based on, because I'm a technical assistant, so what my need is based on what I hear from the government. But it's always falling short. For instance, when I was working in Nigeria, we recruit, and usually the first question is just give me a landscape of health financing in Nigeria. It's blank. And this is someone who studied masters in health economics in Nigeria. So this was not even traveling out. So what's going on? What did you write your thesis on? That's the least that you could have done some literature review through that, and you would have known about the landscape. Secondly, another example, my previous work was in strategic purchasing. And most times our go-to resource is health economists. I don't know why, but they never get to answer strategic purchasing questions clearly. They don't even know what strategic purchasing is. But ask them about Markov models, economic evaluation. They're going to do that. When I talk to the ministry, they don't ask me about Markov models. They want to talk about the policy implications around strategic purchasing. They want to talk about the policy implications around moving money from the national government to the primary healthcare facilities. So that's one point. Are we training for context, or are we just training for the theories? The second point is that are we absorbing the capacity that we are training? And I'll give you one example. For those that know AMREF, we only started doing health financing recently, courtesy of Spark. And at some point, we started going on some scoping work across our countries. Turns out that there were health economists in AMREF who actually even lecture in their universities in the countries where they work, but they were not doing health economics in AMREF. They were doing M&E, nutrition. They were lecturing. So these are not just I studied, they are actually practicing as lecturers. They were supervising, they were raising new talents, but they themselves were not practicing. So again, if we keep talking about building capacity, but we're not talking about the demand side, what's going to happen to all the capacity we're building? Is there really demand enough to absorb the supply that we have created or that we're going to create? Thank you.
That's very thought-provoking there. Matching training with needs. It's a very important one there. I like that point of matching training with needs, and going into an interview and asking someone about your country and you have no clue. It's like when you study general economics and then you ask, can you please tell me the structure of the economy? And you go like this, then we know there's something fundamentally wrong with your training in economics. Because that's where you start from. I mean, if you don't know the structure of the economy, you're not yet starting. So any other question before we get women? We need more women to speak, please. We need more women to speak.
Hello, everyone. I'm Sharon from Zimbabwe. I'm a lecturer at a local university in Zimbabwe. I'm also a PhD candidate with the University of Essex starting October. So thank you, John, that you mentioned that you need women. So for me, this is a feminist solidarity call for me. So to all the ladies in here, I have a question for you. And I also need to prompt you to think about women. Thank you guys for this panel. So it might be the first panel that I've seen more women on the panel as health economists than male. So it gives me some hope here. So I know people have been emphasizing on the need for more health economists in Africa. So I would want to say to women, you'd agree with me that yes, there is a need for health economists, but if we don't put in place measures to make sure that in this race that we are now trying to build capacity and trying to make health economists, if we don't put in place measures that really promote women engagement, then we'll be left out and we'll find ourselves with panels like there are 4 men and 1 woman on the panel. And I also wanted to mention that it's really hard for women, young women. I've worked with young women in other spaces, in youth development, in all other spaces. Usually young women from marginalized communities find it very difficult to penetrate platforms like this one. I can talk about myself as a young health economist, just finding myself at IHEA Congress. You guys, it's very hard. So a question to women is, what are we doing and what innovative methods should we employ to get us on the table, to get us on the train where people are trying to train health economists? That's the first one. And then one panelist mentioned something to do with if you're going to be hiring for a position and there's a woman and a man, probably you hire a woman because you're trying to, get the equality and equitable, whatever. And then it gives you pressure to prove that you are here because of the skills and not that you're a woman. So what are we also doing to ensure that we create an environment up there for women who are hired to not put pressure on themselves, for us to not work extra hard just to prove that we are here because we have the skill set? So really, I wanted to prompt you guys to say, what do we do as women? Because we need to be on this train. If we don't do it for ourselves, sometimes we just find ourselves outside of the rooms where adults meet adults as men. So yeah.
A very good point there. You want to respond? Let's give a final round to response, then we can wrap up this session. Except if, mic to the, do they have one there anyway? Yeah. Thanks.
Thanks. Two very different but very important topics. So I wanted to make a comment on both of them. Well, you're raising an extremely important point of matching demand and need, and it's something we've given a lot of thought to in some of the programs that we have. So when we speak of capacity building as well, it's not just on the skills side. We may do a lot on creating a person ready to be making an impact, in terms of policy and their health economics or scientific skills. But we also create programs on the demand side, on the client, on the government side, because I think when it comes to, as you said, is there enough capacity to, is there enough ability to absorb? Sometimes the decision makers themselves don't realize where this capacity needs to actually exist. So it seems less now, but with gains in knowledge and working with government, and that on a continuous basis, you can create the demand so that the supply that you're creating can actually filter into those roles. But at the same time, I don't think we can ever expect government to have enough funds to be funding this whole cohort. That's why we have to think of ways in which we had quite a robust discussion during tea about different funding mechanisms. How do we bring the private sector into this? Where can we have government adjacent organizations actually absorbing some of this capacity that we are creating in order to serve this purpose of accelerating growth in public health? So I think we've got to think about it much in quite a wide sense, and by capacitating both the demand side and the supply side. On the case of on the issue of gender intentionality, I'm going to say, I think that's exactly, as we are building up these skills, it is a primary point that we have to take into account. And it's not a numbers game. We spoke about numbers earlier of this, the number of health economists we're trying to train, but it's also not about the number of women. It's about being intentional in your entire process of recruitment. So you do not leave people behind because you never stop to think about barriers that marginalized groups like women have to face just to get a space in the room, as you said, just to get a platform or get a place here. And so in the work that we were doing for our PhD recruitment program that I spoke about earlier, we were very intentional from the beginning through not just now that the students are in and we're training them, but even in the recruitment process. For example, a candidate from Zimbabwe, you know, one of the first things she said to us is, I have a child. Is that going to be a problem? Can I still come to your program? None of the male candidates ever volunteered that they had children, because it was their God, and they had children, but it was their right, their birthright, just to be given access to have an opportunity to interview for this program, as opposed to, I have this barrier. Is it okay for me to be a part of this program? And so intentionality comes in, because now that the candidate is a part of the program, you know, she brought her child with. We paid for her child to come with. We paid for the child's medical insurance to come as well, you know, and then and this now continues over and over. And this candidate as well has recently gone through a terrible medical procedure that has delayed her postdoctoral program. She was on a 1-year program, and now she spent 2 months recovering. Now that's such a loss to her. When she goes back home, you know, is she going to be the developed postdoctoral fellow that she would have hoped to be? So we did two things. We said, well, how are you? Firstly, do you want to go home where you have family and you want to receive your medical care there? And she said, no, I prefer to get my medical care in South Africa. So I said, okay, as a community, we will help you recover, but do you want a family member to come down and help you? Because it was a very invasive procedure. And she was like, yes. So we paid for her sister-in-law to come down and spend 2 weeks with her, only because we had money. If we had no money, we couldn't do this. So may I just say, I'm grateful to my funders for allowing us this leeway of being intentional, because it's not her fault that she had a gender-related health problem. That does not say a thing about her skill level at being a disease modeler in this case, you know? And then given now she's lost so much of time, actually it was on Friday that I offered her another year of her postdoctoral fellowship, so she could now get the full value out of her career. So I think it's very much about not just counting numbers. Yes, we have, you know, 5 women and 5 men, you know. I think it's really about being intentional in recruiting, and then intentional in how you're doing this. So it's the systemic approach. I have no other way of explaining this. We've got to look at the entire system in which whatever action we're trying to do is embedded.
Thank you. That was very powerful. I think I'll just comment on the issue of gender. I think it's a really intensive subject. I once sat on a recruitment panel where we are recruiting. I think it was a personal assistant, and one of the candidates was a man. And when he was asked, why do you think you are the best candidate for this position? His response was that because I'm a man, so I won't have problems. I won't have excuses that I'm going to the hospital with a child. Yeah, so you see, that thinking from the kind that they are better, a man is better off because they want to give excuses to take a child to the hospital, whereas a woman, you are already disqualified because you'll be giving those excuses. I think it's really unfortunate. It's something that I think as a woman, as a career woman, you have to go through. And then growing up in the career, what I also realized is that I think in most cases, women, we are our own enemies. We are good at putting each other down. We would rather promote a man other than a fellow woman. We look at a fellow woman as a competition, which is really not right. So I'm glad with the call from my sister that what is it that we are doing to motivate the younger girl child. I think that should be a call to all of us women in this room. If we are here, it means that we've been given that chance. And I think now it's up to us to also give a chance to a younger woman who is coming after us. We are here. We cannot look at our fellow man as as a competition. I think my brothers there said in his presentation that when you are at that position, you have to look at the success plan. As I live, who am I living? You can't live there working and thinking as if you'll be there forever. You have to create space for someone to come after you. So I think it's for us now, our call, to make sure that we put ourselves in a position where we have to mentor the young ladies who are coming before us. We have young economists in our departments, like myself. I have lots of them, the girls and the men, and I try as much as possible to make them feel that they're just as good as anybody else. If they manage to graduate as economists, health economists or whatever, that means they made it and they have the capacity just like anybody else. So they don't have to feel pressured the way we did in our time, feeling pressured that we have to work extra hard to prove that we can do it. For them, they just have to look at themselves that I have the skill set, as good as my fellow colleague here who is a man, and we can work I can work the same as he is doing and deliver, because we have the same capacity. So I think in that way, as we are talking about building the capacity and strengthening the capacity, we have to make sure that we bring on board those few ladies who are courageous enough to venture into the economic profession. Let's nurture them, let's mentor them, so that they can get to the point where we are or where we aspire to be. I think this is a field where we can look at as it's an equal opportunity field. Everybody can excel in it, so long as you have the will to be what you want to be. So I think that's the message which I can give, which I can say I can give to mentor the young girls, the young ladies. And I think for everybody here, even the men, please help us mentor the young ladies. We need more health economists in this field. We need more to make sure that we make the health sector as vibrant as we need it to be. Thank you.
Thank you very much. I think because of interest of in the interest of time, we will have to thank the panelists for their time. We'll still call on you. You're not gone. We're just going on recess for you, just for you. You're having time to cool off, and we'll come back to you at a later time. So I want to hand this mic over to Dr. Riro, who will help facilitate the next session. So the floor is yours.
Thank you. Okay, so thanks again. A round of applause for John and the panelists. Okay, so we just wanted to go to, I know, I want you to get out your phone. I know in most cases you're told to put the phone away, but this is a session that will want us to get our phones out. So please get your smartphone out. My assumption here being all of us have smartphones. Yeah, so please take the QR code for those whose smartphones are that advanced, but others, you can go to menti.com and enter this code. So for those that their phones can't take the QR code, please go to menti.com and enter that code. I give you about 30 seconds to do that. The other challenge I know is the internet is quite slow. So I'm hoping all of us are able to access the internet. Okay, so how many haven't managed to go through? I'm hoping. Okay, we have, I think we're almost there. We probably 28 now, 33. We're doing good. 34. Okay, so yeah, so maybe 5 more seconds. And those online also, please feel free to join the poll as well. Okay, so on to the first question, and I want you to go. So who's in the room? So so this, one of the things that we just want to know is just get to understand where we are at, who is here, and so who's in the room. So we have 5 options. So please choose where you fall under. So you're either in university, in the government, just next. So you a research institution, a funding partner, your technical, by technical partner, I mean NGO or implementing partners. So funding partners, students, okay, yeah, you can see a student, a government, MOH, and this could be any other institution within the government, just to take care of Regis, because Regis is wondering, I'm in the government, but I'm not in MOH. Yeah, so how far are we? The government, 21%, university 31. Okay, good. Fantastic. So I think clearly we know where we fall. So there are technical partners at 37%, then followed by universities, then government, funding partners, then student. So thanks. We can go to the next, because this is important, because it helps the next questions that we're going to have, that we know who to target in the next questions. So where are we coming from? So this is about the countries that you're coming in from. So please answer where you're coming from. Yeah, we'll see where the big number will be emerging at some stage. Okay. Okay, South Africa is leading. Okay, Malawi. Okay. Where are we now? Okay. Yeah, you can see a small Rwanda somewhere there. And there's south. There's something south. No, there's something down there called. Okay, good. So I think we can see how the distribution is. So, you know, it's varied across a number of countries, and that helps in terms of the questions we're going to have, where the contributions that we'll be getting from those questions. Okay, next question. So majority are from South Africa, United States, Malawi, and Nigeria as well. So this question is, what is the most pressing health financing capacity gap in your context? So this could be in your country or the workplace that you are at. But we wanted to use maybe 3 words or less, because so not to make it a long sentence, but we'll appreciate if you can do 1 word, but just in case it necessitates, do a max of 3 words for this. So what is the most pressing health financing capacity gap in your context? Go. Yeah, feel free to write any word. So we'll get a word cloud coming up. Good. Yeah. Good. It's forming good colors. Our good friend funding is on the lead. Okay. A good friend funding and training are doing well, and mentorship coming close, evidence-based inputs. So thanks again for this. And how helpful this is, it's really demonstrating some of the conversations that we've had in the room, like what, you know, just capturing some of the bits that we've discussed in the Think Funding and Training in Strategic Purchasing has come up. Oh yeah, you know, Dario was here and mentioned that a lot of people didn't know how to define that. So thanks for this. And I think this sounds quite good, and we'll be happy to keep this on the record. Are we done with that? Maybe we can go to the next question. So now we've identified the gaps, but what are the opportunities? So in this question is, what is the greatest opportunity for expanding sustainable capacity for health financing? So you have 4 options. So one is strengthen the government to university talent pipeline, expanding universities for women, opportunities for women and other underrepresented candidates, optimizing institutional arrangements and partnerships, furthering opportunities for career advancement in in-service training. So looking at those 4 options, where are the numbers? Okay, opportunities for career advancement in service training is having a solid lead. For women, we're having a it's fine. It's fine. But that's a praise result. Okay, so that's interesting, because then it means, you know, of the people in the room, a greater chunk of us, actually 60%, believe that we should actually be investing in furthering opportunities for career advancement, especially in service training. Okay. Yes. Absolutely. I like that. And again, just the intersectionality of it, that even within, you know, furthering the opportunities of career advancement, you know, this of course comes with the gender lens as well. So when you're talking about government to university talent pipeline, you must have an embedded gender lens to it. And I think that would be fantastic. And of course, that also includes optimizing institutional arrangements and partnerships. And I think one of the things that we talked about today, that beyond the individual capacity building, there's also intentionality around how we are in building the institutional arrangement that optimizes that. So I think this has been fantastic. I think that was the last question. Yeah, so this, we just wanted to see, you know, and especially the conversation that we've had, get to engage you and see how well this has been. So we'll go to the next phase of questions, which really will be built on this. So based on, we've already identified who's in the room, and to a large extent, now we understand some of the issues that have come up, and we wanted to engage the participants in some of these emerging issues that we've talked about, and we wanted to have them to have a look at them in a lens of 3. So what are some of the questions, especially for government partners, and then look at academic institutions, and finally look at development partners and private sector. And for the government, one of the things that came up this morning, especially, I like one of the ways in which Kate put it, that the institutional arrangement sometimes, you know, the dynamics around cadres. So if you're a common cadre, then you are quite fluid in terms of how you move, but you're in a specialized cadre, then there's limitations to what extent you can. So there are a couple of things that we talked about this morning, but I wanted us to, maybe for those who, I know we had quite a number that are coming from government, there's about 30% in the room. And this is really a set of questions that I'll wish maybe some of you to respond to. And the first question being, what institutional arrangement could be better leveraged to build capacity and generate actionable evidence for health financing? The second one is, how can university partners best support investments in health financing capacity? How can universities and partners best support investments in health finance capacity that can be sustained by governments? And third one, what changes are needed to increase gender equity in health financing expertise and leadership? And finally, how does health sector expertise in financing need to evolve to better shift domestic financing and increased engagement to ministries of finance? So this is a set of questions for those from the government partnership, and I wish maybe to get sort of reflections from the participants that are coming from the government and other policymakers within the government agencies. Yeah, thanks. Microphone, please.
So you've used the word health financing, which I think is important because it's not health economics.
Yeah.
And health economics is a branch basically of health financing. And health financing is a practical, has a practical component to it. It's a bit like the earlier comment that was made, that when you ask somebody who'd done a master's in health economics and they didn't have any knowledge of the financing framework in their own country, well, that's not typical only of Nigeria. It will be the same in South Africa. So the issue is really that there isn't, first of all, a clear academic there isn't an academic discipline for this. And this is part of the problem, is that people respond to the disciplines that exist within the academic environment, and the academic environment hasn't responded to the real world to say we actually have to create capacity with this kind of mixed ability. If I go to a government department in South Africa and they will tell me we need to send our people on health financing, our people working on health financing, to a health economics course, and I say you don't need to. They need to know how to budget. They need to know how their system works. They need to know how to pragmatically prioritize. They need to know how systems work. They need to know how to make decisions lower down within the system. All of those things are a mixture of different disciplines and understandings from a practical real world environment. So what I'm doing is actually just posing the first problem is, what field do we think health financing is? And do we need to put a line around, put a border around it and make it clearer so that it becomes a career opportunity? And I'll make one other comment in that if I'm at UCT, and we've got people doing undergraduate economics, as they get to about the end of the second year or third year, the top students in that all switch into actuarial science. And 50% of the actuarial science students are being funded now with subsidies from, say, Discovery Health. They're becoming health actuaries. Theoretically, they're in health financing. They know nothing about health financing when they come out of that. They know how to price insurance products. So the issue is people are responding to that. We haven't actually created it. So I think it's really important, but it means we've got to create a field for it so that people, when they do the programs, know that they've got a career pathway that makes sense. And when we're putting them in real life positions where they've got to work, they know what they're also meant to do. And at this point in time, they don't. They will have to learn it by doing at the moment without a lot of background from the what they could learn at university.
Yeah, thanks for that. And I think it's a recurring theme around how we're having this intertwined relationship between universities and governments. So continuously trying to see who is responding to what and how can we best build that relationship. Any other response, especially on this set of questions for government and policymakers? Joan? Regis? Okay, since the two of you were not ready, someone has taken over. Okay.
Yeah, thank you. I'm Emily Chira from Malawi, Minister of Health. I wanted, first of all, just to add to the gender debate that my director here. So from the ministry, the team of 5 people who are attending are here. There are 3 women and 2 men. So she's doing her best to make sure that she's exposing all of us to such. Otherwise, I am not a health economist. I'm a development economist. But one thing that I feel like we need to also, as much as we need to train, to have the capacity to train health economists, we also need to have some bridging courses for people like us. So this is an appeal to the universities, to the partners, something that will just make us understand and appreciate. We are there at the moment. As we are training, the people who are already in the system, they are not health economists. They can be given that access to just do some bridging courses so that we understand these things. I want to upload the WHO. They've got an online course which I've done in health financing. It's a very good course. It gives you the insights, you understand, and you can sometimes, when I remember my colleagues from Ministry of Finance were like, now you are talking like you have been in health all your life. It's because of such. So my point is, can we have more of this so that the people who are already there can also be given a chance to understand and appreciate? And on the engagement with Ministries of Finance, I'm happy with the health financing dialogues that I know AU has been pushing from our side in Malawi. It gave us a chance to also sit down, talk with Minister of Finance and make them understand that health spending is not just an expenditure, it's an investment. So we are continuing with the dialogue, and my other contribution would be as much as we do these conferences, we need to open it up a bit so that even people from Ministry of Finance, they participate and appreciate. I think it also give us a space for them to, and also take it up at the political level as we are engaging maybe at AU. Let's make sure that we've got sessions whereby ministers of finance, ministers of health sit down and talk. I think it also give us space down there as we engage our ministers of finance. Thank you.
Good, thank you. And clearly what I got from this is you're among the 60% that you're talking about advancing, that how can optimize advancing those who are already in service. Thanks for that, Bridges.
Thank you. I think maybe if I start with the intervention from the person from South Africa, I think the example he gave on actuaries, I think it reflects also how the insurance market is, with more of private health insurances that will recruit those young people. But for countries like Rwanda, where government insurances, so private sector private insurance cover all the 6 insurances we have, cover 1% of the population. So the demand for that kind of skill is limited, and there is a huge demand from both the Ministry of Health and government insurances because they cover majority of the population. But there is no supply, unfortunately, from the universities, and it's always I don't know what is missing because we have been saying we need these skills, and I think kicking off a new program in the university is not an easy process. Sometimes they need to be pushed. Maybe it's a call for both government and partners, because we see partners coming to us with short-term training, technical assistance, whatever, as I was saying in the morning. How can we also give a portion of those resources to the government, at least to kick off some short courses and leading to long-term training, kind of masters and PhDs. I think that start of the program is what we have not seen. I've heard a number of countries having, I think Malawi, Ghana, and others. I don't know, maybe it's an experience to share. How do we get universities starting these programs that respond to the problems that are here, that are within our institution? Have we seen any example of donors actually supporting university to start a program like that? Because I think I'm insisting on the word starting, because in the future it's self-sustainable. When there is demand, people will be employed and people will be paying their own tuition fees because they know there is a job in RSSB, in the Ministry of Health, that is waiting for them. But we have not been, I think, it's always also a chicken and egg process. What starts? When we advertise jobs and we put health economists, we know no one will come. And when we lower it and others come and they realize, actually I can get in there without the training. So it's, I don't know how restrictive we can be for people to see that there is demand for these skills. I don't know, there is no answer, but I think it's more questions I'm putting here. Thank you.
Good, and thanks, Regis. Yeah, so I think a couple of points as raised, which I think are quite pretty helpful. But one of the things that came up, which will again come maybe later in the conversation, is around the role of funding partners in terms of getting this started. So that's a question, of course, you're putting across, but that will be addressed in the last set of questions. So let's go to the second set of questions, which is looking at the academia, so the academic institutions. And universities. So looking at what approaches can be used to link universities, the research institutions, to governments to address health financing capacity gaps. The next one being how can we evolve training programs to foster fit for purpose health workforce? And I know this is something that was talked about early in the day with a focus around mentorship, but happy to hear what those coming from academic institutions have to say. Then what has prevented effective collaboration and partnership with governments to generating and using evidence for health financing policymaking? Yeah, any sort of responses from those coming from the academic institutions? Yeah, okay. There's one hand there, there's another one here.
Well, for me, it's not really related to those, but I think from what I've observed, I think what she presented is refreshing. I think where the investors should change. I think now they do research in terms of responsive research, where like things already happen. Like I've seen a lot of research on PBF, RBF, purchasing now. So they wait for the ministries to implement, and then they go and research. Then they wait again. So they're not very proactive with regards to leading some sort of thinking out of the box compared to what we see in other fields like agriculture. You see in other fields where the investors come up with their own out of the box thinking. In health, they just respond to what policymakers are doing, and they do it badly because the implementers would already, for example, I'm doing PBF. I design it in such a way that there's something I'm looking for. And then someone comes and say, does PBF promote equity? That is not what I wanted to do in the first place. Maybe I was implementing it for strategic purchasing and things like that. So I think the universities should be universities. I think that they are now more responsive to what is existing than leading the teaching.
Okay, good. Okay, maybe we can have her, then Alex. Yeah.
So I was going to comment on the first set of questions, the last one.
Yeah.
Which say, how does health sector expertise in financing need to evolve
yeah.
to better a shift to domestic financing and increased engagement with ministries of finance? And I think my response will also speak to the effect of the last one on this slide. So I want to raise something, understanding the political economy. So what I've realized in my country is, as health economists, maybe you have all the expertise that you need, and you understand the context in which the health system is moving, and maybe you even have evidence that we should be doing this in policy. But if we don't invest in understanding the political economic context of the country, we might not really get our evidence into policy, because maybe the goals and objectives of the Ministry of Finance and government are totally different from what you're trying to push and move as health economists. So maybe we need to invest in understanding relationships and actually building relationships with people that matter and people who are in positions where they influence policy making.
Okay. Fantastic, Alex. No, it's your turn now. Yeah.
So first of all, universities themselves have their own constraints. So when you're looking at the teaching programs versus research, research has to be funded, and it's not necessarily, unless it's supervision, it's not funded by the teaching program. And so the universities are typically under stress as to what they do invest in and develop. So what is essentially being asked for in this discussion is to, on a collaborative basis, develop new curricula for what would fall into the teaching rather than the research program. However, the teaching program should be informed by the research program. These don't necessarily meet. The comment that was made earlier about people who are teaching who've never actually practically applied anything that they're teaching is wrong in an applied field. This is an applied field. It is not a theoretical field. So somebody who, for instance, wants to do strategic purchasing and all they've ever done is undergraduate economics. They think supply meets demand at some equilibrium point between price and time. They have no idea of practically how, in a real world, you try and optimize your purchasing arrangements, and it's experiential, it's experimental, it's not academic. Now, you have to have people at least have an entry point into that type of thinking in order to have any kind of ability to do anything in a practical world. So in terms of curriculum, you're actually designing something that isn't textbook. But it's worthwhile doing. But the exercise is collaboration on curriculum development, understanding that it has to survive within the university environment. In other words, there must be students who come and pay for it, and that can sustain a staff that can actually teach the program who have a background of both the academic and the practical field. And in terms of supervision, that's also very onerous. So you also have to look at how you're going to be able to supervise people doing practical research in the field. So I think that this is the practical problem. I don't think that it is that it can't be overcome, but it is about essentially a process of engaging between all the people who have an interest in designing what the university does, and then it will be useful. But it's not an easy step.
Okay.
Not an obvious step, let's say.
Good, thanks. Maybe someone behind you, Elias.
Thank you. I would just like to add from what is already said, but especially for the countries, they need to have a priority research agenda and then bringing all those partners on the same platform. I mean, like the research institutes, they may have their own priority agenda, and the academia, the students will do the other way. So I think we need to channel this in the same platform, and then bringing the academia, especially with the priority research agenda. If you have the same understanding on the priority research agenda, then the academy institutes will assist to fulfill all those agendas. So I think, so I would like to emphasize to bring these partners, the universities and the governments on the same platform, and making ensure to have a clear, priority research agenda for a year. And then, that will really help for the countries to move forward.
Good, thanks. Maybe we can have the last one here. Last contribution, thank you.
Okay, thank you. This is a very good discussion. I was in academia before I shifted now to technical work. And I can see in training curriculum or curricular development is a very big gap. I come from Kenya, where I think we have only one institution offering health economics and policy, I think University of Nairobi. And then the other universities are offering a course in health systems management, which now has everything alongside the building blocks of the health system. And you find that we really have a gap. And so even as you talk about the training curricula and, training this health workforce. So the question is, do we even have the faculty? Do we have the capacity to train? So that is where we have a gap. We really don't have enough faculty to ensure that we now take in these people to train and fill in the capacity gap in healthcare financing. And so the other thing is about bringing together the industry and academia as they package their training curricula. Because if you look at the curriculum, most of the time it's just so theoretical. And me having gone through the training, when I come out here, yes, application, but I find there's a very big disconnect between what I was taught in class and what I'm seeing outside here. So there should be, when you're developing the curriculum, then you need to bring the industry in so that you are developing a curriculum that is addressing the need. Okay. Then lastly, I think he left. He really aroused some emotions in me. Just a short story. So we have this medical doctor who decided to go back and do health economics because she saw this need for a health economist in the Department of Health where she was serving. So she was given a 3 years of study leave. So she went to the University of Nairobi, did her course, finished. When she came back, there was no space to practice her health economics. So recently, she was posted to a sub-county hospital, and she felt, I'll have skill decay because I have gone back, I've gone to school to do a postgraduate course in health economics. I'm back and I'm being told again to go back to bedside. So she went to the management and told them, no, I'm a health economist. And they asked her, who is a health economist? What do they do? You know, and I felt so bad. I'm like, can't this government, the Department of Health, see the need for an economist? Or is it that they feel like this aspect of, using evidence to, it's the reserve of the development partners to come and assist us to, so we really have a problem, like from where I come from. We still don't have a space for health economists to come and practice. And even like department knowing that they have capacity within themselves to, to run their affairs. They just depend on development partners to do that. Yeah.
Good, thanks. And we'll have the last slide on technical partners. So this maybe we'll take 2 or so questions, contributions to this. So what is the role of regional institutions? And I know, so by that have, Africa CDC and, the RECs that are in the room around fostering sustainable and diverse talent pipeline for health financing. The second being, where are the key opportunities for catalytic investment by development partners to increase regional pipeline of expertise? And the third one, what has previously prevented effective collaboration in this area? And happy to hear from, technical partners, funding agencies and private sector, just in case there's any in the room. Any reflections on this? Yeah, I think John pointed out the World Bank.
I think for the first two, I think it depends on the instruments we're using. If it's a World Bank, I just talk about World Bank. So if you are using a regional project, so you have seen us engage more and more with the regional institutions like SADC, ICSA, and the rest. So that is very much possible. And obviously what the Africa CDC was talking about, we have a huge project with the Africa CDC. Now, when you're using an instrument, which is at national level, we call it investment project financing, which is government, World Bank to government. It depends on what the government wants. Some governments would say, as part of the project, we need so many PhDs and so many masters. I was leading a project in Uganda where it's clearly cut out. Some governments would say we don't need to spend money on training. So it depends on what the government needs. So us, we just listen to what they need. So if you want to hold us accountable to increasing capacities, then we need to engage more with what the government, the design of the project is. I've seen more and more now the governments, even for the investment portfolio financing, them put in some PhDs, masters. But I should say that in some countries we do put those, but then the government waits until maybe a year to the end of the project. That's when they want to send someone to school. So we always encourage them, when the project just starts, then you already engage with the universities and then bring us the acceptance letters. So it's something which is doable, but it has to be very systematic. So I think there's not been a problem on this. And also within the space, we do have short-term courses. I'm sure you've seen some of the courses on the website, the PhD financing courses and all those things. So I think we can do both long, short, medium term training.
Good, thanks. Maybe a last comment from the room. Okay, we'll have 2 more comments and then we close.
Yeah, I think this, especially these 3 slides, have been quite insightful. I'm just trying to bring all the conversations together. But from where I come, what I see perhaps emerging clearly is there is need for a starting point. Okay, for me, I feel the starting point is, can we work to get our governments do some health system reform, where the health financing unit is institutionalized within health ministries? You don't get this across always. And so once you are able to get that unit institutionalized, and the requirements of who gets there are clearly spelled out, then their job description can all be fleshed out to include all these conversations, the networking with universities to ensure transfer of knowledge, use of evidence, and what have you. And you are now given the health financing or health economist place on the table in the ministry, such that their inputs are accepted and recognized by the political leadership. I think perhaps this sort of reform, we've seen it work with Human Resource for Health, where you now have units for Human Resource for Health that are consulted. We've seen this with gender mainstreaming. I think this will be quite an opportunity to start with, because even universities will still need that entry point, and unless they are called upon, it's unlikely the evidence that they will bring will be translated. Thank you.
Good. So our last contribution from just on the same line. Oh yeah, over to you.
Thank you for giving me the last chance. Okay, I just wanted to raise a last point. I am Maskaram, I'm from the LSE, the London School of Economics. I just wanted to re-emphasize on the point about research funding and making research funding available, particularly for research institutions and universities in the African continent, so that we do all of the things that we've been talking about, regarding setting research agendas, but also training researchers in the area, but as well as retaining talent, because what happens is people train in postgraduate degrees, advanced PhDs, and then they don't come back to these institutions that really, really need them. And so these can create further opportunities for professionals to stay within the region as well. So I just wanted to make that last point. Thank you.
Good. So thanks again. And I know, it's been quite a helpful conversation, but I just wished we had more time to talk through this, because they're pretty heavy questions, and I greatly appreciate especially the contribution that you've had from the team. And it's at this moment that I'll wish to maybe welcome John to give maybe just, some wisdom around some of the bits that have come out of this conversation. Then maybe after that, he can welcome Professor Justice Novignon to close. Thank you.
Thank you very much. That's, I don't know whether I have the wisdom. That there's a proverb in my language that says, when I give the proverb, it's not intuitive, but I'll tell you what it means. That when a king sends you on an errand, think. And that's just a proverb. When a king sends you on an errand, think. The reason is that a king will send you on an errand to another king, and his message is, because usually a king, his message is, go tell the other king that he's a fool. That's the message. So how can you, as an errand boy, go deliver that message to the other king and tell the other king, my king said? Because by the time you do that, you're already a slave. So that's how people are captured and put into slavery. So when the king sends you that message, just know you just find your way. You've lost your kingdom, you've lost everywhere. Just go. Just go. So it's a message that sends you away. Maybe you want to send me away by saying, I'm not, I don't have the wisdom. So without further ado, I think we have really touched on very, very important points here. How to build capacity on the African continent, not necessarily training people on the continent, but anywhere they are trained, but bring them back to ensure that they contribute to capacity development in the country, in their countries. Now, there is the issue of redressing existing inequalities in terms of gender, race, or any other stratifier you might think about. So these are things that we need to think through. We'll carry this forward tomorrow. We're going to have what we call an All Africa event. And so it's a walk, like I said it before, it's a walking and shopping workshop and eat and chop, whatever you want to call it, at the Gold Restaurant. And it will start around 7:30, 8-ish, thereabout. So we will gladly welcome you there so that we'll take forward this. You see some items on the agenda we couldn't finish, we'll carry them forward there, and we'll pretty much trash them out. I know my boss is waiting at the back there. Because if you are working with the Africa Centers for Disease Control and Prevention, you lead Africa. So I would want to welcome Professor Justice Nomignon, one of our own professors in health economics on the continent, to pretty much give us a closing remark. And I want to do that so that he comes. If you also read the Bible, also there was somewhere where someone in the Bible talked about that he cannot undo the straps of the sandal of somebody else. And that person's, I learned that the person's name looks like my name. So so maybe there's something playing out here. So maybe I cannot undo the straps of the one who's coming. And the one who is coming, his name is he does justice. And the one who does justice might also sound like the person who John could not undo his strap. So maybe something is happening. So without further ado, I want to welcome you here, Justice.
If John wants to put you in trouble, he knows how to interpret. But ladies and gentlemen, I think it's been a great conversation. As an academic who is now at the Africa CDC, I find myself at both sides of the conversation. And I pinched myself not to make comments, because we did agree that this was a platform to hear from you. So this conversation about health economics and health financing, it can be controversial, but it can be tricky. My own view is that any program in health economics that does not train students to understand and practice health financing. Of course, there are other aspects of health economics, right? You know, efficiency, equity, and other stuff that may not necessarily be. But any program that is training people to go into the ministries and work and cannot provide them with the skills to practice health financing is not very helpful. Do we need a whole new discipline of health financing? I don't know. Because health financing also goes beyond budgeting. It's essential about resource, acknowledging the scarcity and resource allocation and efficient resource use. So you still will need some economics perspective. But the long and short of it is that recently, when the CDC was being restructured, when I got to the CDC, actually the name of the program was to be a health technology assessment program. And I said, I don't think we need an HCA program. We need a health economics program to do a lot more things. So recently, when we had an opportunity to restructure, I proposed to management that, you know what, let's add financing to the name and make it health economics and financing program. And this was approved. Just so we understand that financing, for me, is one of the practice ways of health economics, especially as far as governments are concerned. Of course, there are other things that governments do beyond financing. But a key thing is, how do we help governments understand or appreciate resource scarcity and make decisions in a way that, you know, makes sufficient use of resources in terms of raising and using and all of that. And Waishita, nice meeting you in person. We've been talking for a long time, but I obviously was very impressed with the comments you made about gender. I've always had women around me growing up and, you know, in my whole work. But and I think that when I recruit people, especially at Africa CDC, I have not taken steps to favor women per se. And I think that's not good. But what actually has happened is that I found the best, because I don't want to come out of a process today to say this person is in the position because she's a woman. But actually, I've had most of my staff being women. but I think there's a bit more we can do to make the space a bit more, easy. Of the 7 technical health economists that we have, PhD health economists, 4 of them are women at Africa CDC. And I think that, in fact, the AU itself, the AU recruitment interview sheet has a special score if you're a woman. If you're a man, you get 0. If you're a woman, you get like 3 or 4 on that point. So we're trying to build that in, but I do understand that there's a lot more we need to do. I honestly don't think there is not capacity, especially when it comes to health financing, because most of the strong African health economists I know are women than men. The other challenge is for us in positions in government and other places to find ways of making it a bit easier and bringing these people. And I look forward to a day when the AFIA executive director will be a woman soon. So we really appreciate, all the discussions that have gone on. For us at Africa CDC, let me say that our interests, I'm an academic, but at Africa CDC, we are only interested in academic health economics if it addresses policy needs, because Africa CDC is a policy organization. So where you see us, we always come into the discussion with policy. So how can we, leverage academic capacity to meet policy needs? And the discussions that have happened today clearly show that there's a huge gap. The gap is huge, and the road to filling that gap is very complex. We will try at the Africa CDC, we are leveraging our competitive advantage in policy to drive the policy demand, and working with other partners, mainly academic partners such as AFIA, and technical assistance organizations such as CHAI and the others, to see how we can marry these two. And we will continue to work with these partners to create the platform for all of us to continue with this conversation. The last thing I want to say is that John Matiko this is the 3rd meeting we've had from Washington to Addis to Cape Town on this subject. I hope that our next one will actually be action. Because often we are good, for us in academia, and we are good at having conversations and keep having meetings and meetings and meetings. But can we go the way that Sheetal is going and actually act wherever we find ourselves, even in academia? Make space, to close that gender gap, make space, get out of our comfort zone, because academics are not usually easy to get out of our comfort zones and meet policy. And until I got to the CDC, I realized that sometimes the understanding of what policymakers need is quite different between academics and policymakers. For instance, an academic will say, policy brief. I know how to develop policy brief. Yes, we all do. We learn how to do it. But when you are sitting on the other side, you are looking at it differently, because you want to convey the message in a way that a policymaker can pick and run with. And for us, coming back to the issue of financing again, it's very key, because we are dealing with countries. We recently have recruited a young former finance minister to join my team. And the purpose is that we acknowledge that as economists, we often do not fully appreciate the finance perspectives. And for us as health economists, our job is often also includes bridging that gap between health and finance, because there's a gap even in government. We need to ensure that the finance people can meet with the health people and try to close that gap. And this is what we are seeking to do. So we are not only, participating in meetings, we are seeking opportunities that give us the that leverage our advantage to go knock the doors of a finance minister and say, hey, can we have a conversation using economic evidence? So I want to thank all of you for spending your, how many hours? 4, 5 to be in this conversation. This conversation will not end, but hopefully there will be more action beyond this conversation. and we entreat all of you to work with us because Africa belongs to us. And at the AU, we say it has to be the Africa we want. You know, any other support we need, whether financial or technical, would have to be the way we want it because we understand our problems. So let's embark on this journey together and ensure that the next 5, 10, 20 years, we'll be having a different set of conversations around policymaking on the continent. So thank you very much. And on this note, Matiko, if you have any other logistics announcements, but it's always good to be the one to close the meeting. So thank you and have a fruitful conference.